Okay. Hi, everyone. Thank you all for joining us for Lotus Project's second webinar of this series. And I want to excuse myself for this voice. There's like a cold going around, but bear with me. For today's webinar, along with the entire series, we hope it'll spark more discussion on how we can better support the mental health of Asian American and Asian immigrant communities through culturally sensitive and trauma-informed clinical practices. And before we get started with the content of the webinar, I'll just go over a couple quick logistics. So this webinar will be recorded and uploaded onto the Lotus Project website in this week. And we will follow up with an email with a link to the recording, along with the feedback evaluation form and additional information. And in this webinar, there's a Zoom chat as well as a Q&A function. So feel free to use the Zoom chat to introduce yourselves, engage with one another, let us know where you're coming from. And then the Q&A chat is specific for questions that you have for the presenters and around the webinar content. And so you can upvote questions that you resonate with the most or are most curious to hear the panelists discuss. And given our time constraints for the webinar, we'll most likely only be able to pose about like 2 of those questions to the speakers, which is why the upvote function is important. So vote on the questions that you think are the most important. And lastly, just please use respectful language in the chat and in the Q&A. And if you are seeking continuing education credits and need your attendance recorded, then make sure you type in the chat your full name along with like parentheses CE credits so that we can record that afterwards. And also be sure to submit the webinar evaluation, which we'll send a link to at the end of the webinar in the chat and also in the follow-up email. And then your CE certificate will be emailed to you later this month. And with that, I will introduce our moderator for the remainder of this webinar, Angela Tang. So Angela is a licensed clinical social worker, certified in healthcare compliance. She is currently the Chief Operating Officer at RAMS, Richmond Area Multi-Services, which is a nonprofit agency in San Francisco that provides and advocates for mental health and wellness services, centering clients, community, and culture. And they also have an expertise in serving Asian and Pacific Islander Americans. And Angela is also a member of the Lotus Project team and has played an important role in the collaborative partnership we've established between the Public Health Institute and RAMS. And so I'll let her take it from here and introduce our first speaker today.
Thank you, Ellen. Hello, everyone, and welcome to this webinar series on racial trauma among Asian American and Asian immigrant communities. Today is the second webinar of the series, and focusing on implications for clinical practice. I'm pleased to be able to introduce our wonderful panel of speakers. Our first speaker is Dr. Chris Hahm, who is a professor and associate dean for research at Boston University School of Social Work. Dr. Hahm has been funded by the National Institute of Health through multiple grants, including a dissertation grant award, a diversity grant, a career award, and a clinical trial planning award. Her research includes randomized clinical trials, survey and qualitative research, and large database studies. Her current research focuses on Asian American women's health, risk behaviors, mental health, and intervention development. She's worked as a psychotherapist in New York City, treating individuals with mental illness and substance abuse issues. Dr. Hahm is also a licensed clinical social worker who received her Ph.D. from Columbia University. She completed a postdoctoral research fellowship at UC Berkeley before joining Boston University, and has served as a visiting associate professor at Harvard Medical School Department of Psychiatry. Please welcome Dr. Hahm. Thank you.
Thank you. Hello, let me share my screen. Okay. So I wanted to present this study. I'm going to talk about 3 published paper in the time that I have. Actually, the title of this study is the impact of COVID-19 anti-Asian discrimination for Asian Americans as well as non-Asian Americans during the first year of the COVID-19 pandemic. So all these 3 studies that I'm going to talk about focuses on what happened during the first year of COVID-19, which is the year 2020. So you're looking at this picture. This is a beautiful university called Boston University where I work. Do you remember this time? If you remember this, COVID-19 pandemic, it was so devastating and so deadly during, which was a global crisis, right? And this picture was taken by the drone during the lockdown in March 2020. And this really shows a glimpse of normally bustling campus of Boston University in Boston, Massachusetts, but now is so quiet and empty. This is a picture of New York City. And this also captures the emptiness of downtown New York City. The streets are deserted and abandoned. But here's the irony. The irony is that while these physical cities may be very dormant, but in contrast, the discrimination against Asians has been so loud, so violent, and so abusive. This picture, taken in San Francisco, California, serves a poignant reminder that blaming against for COVID-19. This is a vandalism photo. What's interesting thing that we have all observed during this time was that anti-Asian sentiment escalated from microaggression to physical assault, vandalism, and even murder. And I've been thinking about a couple of words which describes all this violence, maltreatment, and abuse. And I came up with one word capturing all this. There was dehumanization. And vandalism is also a very powerful tool because it instills fear to every member of the targeted group. So today what I'm going to talk about is the impact of COVID-19 anti-Asian discrimination. So first, I'm going to talk about how prevalent was COVID-19 anti-Asian discrimination during the first 3 months of pandemic. The next one is that what's the relationship between this anti-Asian discrimination with mental health and suicide among Asian Americans? So these are, the first one is the first study and the second study, okay? And then the third study, this is really interesting because I wanted to capture whether the anti-Asian discrimination is having an impact on Asians as well as non-Asians. So we interviewed both of them, right? So the first one is a type of discrimination that we have discovered. And the last one is effective reactions by the anti-Asian discrimination. So all the studies, those 3 studies have been funded by NSF, NIMH, National Institute of Mental Health, and PCORI, which is a Patient-Centered Outcomes Research Institute, Boston University, and Harvard Medical School as well. So the first paper, the title is Perceived COVID-19 Related Anti-Asian Discrimination Predicts PTSD, Post-Traumatic Stress Disorder Symptoms Among Asian Americans and Asians, Young Adults. So for this study, we were very fortunate that as soon as COVID-19 came and started affecting US, we applied for a grant to NSF, National Science Foundation, and we were able to acquire the grant, and then we were able to roll out online survey data. So we were able to get the survey data over 1,300 young adults whose age was 18 to 30 years old. And this one captured the timeline of the April to June of 2020. And among this, we focused on only Asian Americans and Asians. Those were 212 people. So first, in order for us to understand the prevalence of COVID-19 anti-Asian discrimination, we created a measurement. So the measurement has a series of questions. For instance, did you hear the comment that Asian Americans or Chinese are a source of virus? Did you hear the comment that Asian Americans or Chinese are, have a terrible eating habits? And also, did you hear the comments that people are avoiding eating at the Chinese restaurant? All those kind of things. And we also asked them about verbal assault and physical assault experience. What we have found was that among these young people, 68%, so almost 7 out of 10 Asian American reported that they themselves or their family members have been or have experienced any of these anti-Asian discrimination. So we wanted to look at the association between this exposure and their mental health status. So what we found was that those people who have experienced anti-Asian discrimination had elevated depression and elevated anxiety symptoms and elevated PTSD symptoms. Those are by varied level. So I wanted to talk a little bit more about the PTSD because that's really, really important thing that we are going to talk about today. Now, we hear so many times about PTSD, right? Because we hear so many times like, okay, PTSD, whatever, so people are traumatized and they will have so many reactions. So, but I wanted to like really dive into some of the symptoms that we are talking about. So we used a measure which illustrates 17 items, but here I'm just gonna talk about 6 items, okay? So we're talking about, when you say it's a PTSD, is one of these. Repeated, disturbing memories, thoughts, or images of stressful experience from the past. And you have a physical reactions, heart pounding or trouble breathing and sweating, okay? And feeling very upset when something reminds you of a stressful experience from the past. And you start avoid thinking about or talking about the stressful experience. And sometimes you experience emotional numb, or sometimes you feel jumpy and easily startled. So those are some of the symptoms of PTSD. So you get the point, right? So we did the multivariate analysis. Well, what that means is that we control for all other predisposing factors or factors that we thought that it might be associated with the PTSD, depression, anxiety symptoms. What we found was that even after controlling for their lifetime discrimination, this COVID-19 discrimination, specifically during the time COVID-19 exposure to the COVID-19 discrimination was significantly associated with PTSD symptoms for young Asian American adults. So for this paper, there are key points. The key points of this study is that this study is a validation of the public perception that COVID-19 anti-discrimination was widespread from the very beginning of the pandemic. Another thing is that the intensity and magnitude of COVID-19 anti-Asian discrimination was significantly associated with the increase in symptoms of the PTSD, even after controlling for the lifetime discrimination. That was a proximal risk. So that is important finding for us. Now, I want to talk about paper 2. This was published in Pediatrics. And this one, we wanted to understand youth suicide. This is all different race youth, age 5 to 24 years old. We wanted to estimate the actual suicide events, okay, during the first year of the COVID-19 pandemic. So we used the data set called web-based wide-ranging online data for epidemiologic research. It's called the WONDER data set. So total sample size was more than 5,000. And what we did for this study is an interesting one. We wanted to compare the observed suicide deaths in 5 to 24 years old of youth and the expected suicide death. Okay, so when we say observed versus expected suicide rate method, it is a way for researchers to figure out if the certain group of people are more or less likely to die by suicide than they would have, based on what we know about suicide in general population. Okay, so we are essentially comparing the actual suicide event, right, which is observed, versus what we would expect based on all the subgroup rates of the suicide. So this is what we have found. This one shows, this is a little bit busy, but then it has an actual number of the monthly suicide, which is observed versus expected. And then you can see it is a 95 confidence interval. So when you look at this, if the rate ratio, there's a rate ratio, this is a risk ratio. Rate ratio is greater than 1, that means it suggests that observed suicide deaths were higher than expected. That's what it means. So let's take a look at this. When you look at this confidence interval and that is a rate ratio, which number pops out, okay? Which group pops out? Asian American female, and this is a American Indian and Alaskan natives, male, and black male, black female, and whites, no whites, and, oh, sorry. Sorry. No. Okay. So these groups popped out, right? But then really, when you look at this yellow dots carefully, the largest increase in observed to expected suicide deaths was API, Asian Pacific Island female. They have the greatest risk ratio, rate ratio, 1.39. During the first 10 months of COVID-19. So do you remember this picture? This is what Asian American had to deal with, Asian American women had to deal with. They felt like there was no place in the US or no place in the globe was safe. And remember those Atlantic shooting? 6 women, Asian American women were killed brutally. And there was another brutal killings of young Asian American women in New York City. It was just such a scary time for all of us. So the impact of COVID-19 related discrimination on mental health, maybe there's an underlying factor. And then that's part of the reason why it had a higher than expected among API females. And different surveys talks about different findings, but there was another survey, which was AAPI hate, Stop Hate survey. What they found was that 8 out of 10 API youth reported being bullied, and 8% reported physical attacks. Okay? And API female youth were particularly vulnerable, being 2.5 times more likely to report hate incidents than API youth males. Number 3 paper. Now we are going on. So this one is, first I talked about the prevalence, and then second one was mental health and suicide. And then third paper, this one is going to talk about what types of discrimination that we have discovered and how was the reaction, effective reaction based on this anti-Asian discrimination. This is a survey for Asian American as well as non-Asian Americans. So in the same survey that we used, right, the care study data, we asked these 2 questions, okay? And then those people were, able to type, right? This is kind of open-ended questions. What types of COVID-19 related anti-Asian discrimination did US young adults across races experienced during the COVID-19 pandemic? So these are our questions. Sorry about that. These are the questions that we asked. Are there experiences that we missed in the survey so far that you wish to describe? And another question was, please share what your thoughts about the current political climate. So what we found was that out of the total 1,331 people, we use a two free text, right? And then 611 people actually typed those texts. And then some of the contents were college relocation related contents. The other ones, political climate, various romantic relationship, like I couldn't get married, or, I'm worried about my future romantic relationship, all those kind of things. And then we had about 113 texts regarding anti-Asian discrimination or the racism related comments. So out of this, we were able to develop the themes, okay? And we were able to identify the types of anti-Asian discrimination. So anti-Asian discrimination types were like this: societal level, interpersonal level, intrapersonal level. So 3 levels. So societal levels, what do you mean by societal levels? It's a political discrimination. Do you remember the White House talking about the Wuhan virus all the time? And interpersonal level was a direct discrimination or vicarious discrimination, in person or online. Intrapersonal level was an internalized discrimination. So I give you a quote. So this political discrimination, this is an example. This is reported by a white participant. The current social climate is very tumultuous, with the acts of racism from the police and political racism against Chinese people about the virus. I think it is important for this conversation to happen because being passive is just allowing these problems to continue to exist. People need to understand what is okay and what is not okay. Another one, vicarious discrimination in person. Okay, so it was reported by the Black participant. When I was on public transportation, I witnessed verbal abuse to someone I assumed was an Asian descent. An older male was verbally assaulted by a young woman who was also a person of color. Okay, now let's take a look at second overarching thematic affective reactions. So the affective reaction was, okay, how did you feel when you're watching, when you're experiencing all this discrimination? Mostly it was fear, distress, anxiety, hopelessness, depression, and avoidance. So for distress, anxiety, this was reported by a non-Asian white person. My partner, who is Chinese, has experienced a higher level of anxiety, and I have experienced higher level of anxiety because of their anxiety. So the conclusion of this study is this: what affects one group of people has an effect on the other groups, the other racial groups. We must acknowledge and work together to decrease and combat discrimination as a serious threat to public health. And how do we tackle this? How do we tackle this discrimination? We need to really focus on one place at a time, which is a societal level and interpersonal level, as well as intrapersonal level. So I want to end my presentation with this quote. This quote is several years ago, about 2 years ago, during the whole pandemic time. I was giving a talk like this through the Zoom, and then one of my participants typed when I was ending my presentation, and I saved it. I thought this was so beautiful. I know this person was an African-American male. Asian Americans are needed to be more inclusive in minority fight for social justice. Microaggression toward one is for all. We should stand up together to fight for what is just. Thank you.
Thank you, Dr. Hahm, for that. I mean, I'm just thinking about like how you really highlighted what has happened in the past couple of years and really bring forth the really recent research findings. So thank you for that. And it really, really leads into the implications for our next implications of practice for our next speakers. Our next speaker is Cruz Chang. Cruz is a clinical manager for the Healing for Asians program at RAMS in San Francisco. She's a Cantonese and Mandarin-speaking clinician who graduated from California Institute of Integral Studies with a master's in counseling psychology with a specialization in drama therapy. As Cruz's role as a clinical manager, Cruz is further developing the RAMS Healing for Asians program, which provides trauma-informed mental health services to limited English-speaking Asian victims of crime. This RAMS program is part of San Francisco's multi-system initial answer and collaborative solution to the anti-Asian hate. Cruz is a licensed marriage and family therapist, a registered drama therapist, and actively receiving training in psychodrama. Cruz's background also includes providing mental health services to children, youth, and families, and adults. Prior to Cruz's clinical work, Cruz also participated in many drama performances and was a radio host and producer in Macau. Thank you, Cruz, and I'll let you take it away.
Thank you, Angela. I'm going to share my screen and let's get started. Hi, everyone. So in the following presentation, I'm going to briefly address some potential challenges and resources for Asian American and Asian immigrant students at school base. I would like to share one of my case to describe all the potential challenges for the students. But please know that in order to protect confidentiality of my clients, some of the personal information have been omitted and also changed. I work with this client at a high school base. I work with him for around 2 years. I have him, the referral reason was at that time he was recovering from COVID, having 2 weeks of distance learning. After recovering from COVID, that he started to have a breakdown, that he refused to go to school. He shows like all these depressive symptoms about like, I don't want to go to school. I don't want to get out of home. I feel like I will not be able to have a successful life anyway. I'm such a value. And he started to have like suicidal thoughts. So when I got him, we started to see each other online on Zoom because he refused to come to school and see me in person. And I also have to refer him to see a psychiatrist to have some anti-depression medication as well. Some of the background of this student, he immigrated to the US with his parents when he was in elementary school. So at that time he was like around 3rd grade. He comes to school, he withdraw. He also refused to go to school because like, oh, elementary school was like, it is a new environment, a new language. In hometown, he was like speaking Cantonese, Mandarin. Suddenly come to US, that he finds like studying at school with English is very difficult for him. He withdraw, he was not able to make friends. He has to apart from his parents because he went to school by himself. He also apart from his hometown, he has some friends already at that time in China. So all of a sudden coming to the school actually is also another whole different country for him. And he attended to school by himself. But after several years of elementary school, he was able to survive. He was able to make some friends. He was able to listen and speak in English fluently. By that time, he also being relied by his parents because like he was able to study English in elementary school for several hours every day, per like 5 days per week. And also like for several hours per day and studying in this English environment, while his parents was not able to have this opportunity because his parents needs to work long hours, that they did not have this opportunity. So his parents did not improve their English, but he himself is, so that he started to take care of the documentation, of the translation. And at that time, families started to have stable income. Parents think that, oh, this is a good time to have like more children. So suddenly that he also have a lot of like younger siblings that he started to take up a caretaker role. So at that time that parents say, oh, we come to the US because we want you to have a better life, right? Because we ourselves, we are not able to have a better life. So we want you to be like, make us be proud of you. But also on the other hand, he also feels that I have to be the role model for my younger siblings. So with all this expectation that he feels very stressed when he was in middle school, he started to feel why I'm so different from my family. All of my younger siblings, they were born and grew up in the US. They did not really think about who they are. They just think I'm Americans because I born and I grew up here. And my parents, they came here when they were adult. Just me, myself, when I came to the US, I was young, I was little, and then now I also have friends in the US. So who am I? He started to have some this like confusion. When COVID hits, he was like not going to school for 2 weeks after recovering from COVID. He was worried that when he go back to school, he will not be able to catch up of his academic requirements. He was afraid of his friends will bully him or like laugh at him. Oh yeah, you have virus, your body have virus. That kind of jokes that really stress him out. He refused to go back to school because of all these things. So for the very beginning of the treatment, we saw each other online on Zoom, really just build relationship and also to challenge about his self-doubt and also the negative thought about himself, like, oh, I'm such a value, I will not be able to have like successful life no matter what after all these things. So we were really seeing each other to just build relationship and also like building trust and also to start to challenge a little bit, wait, is this true? So we started to have able to have like some distance about, okay, this is the situation for now, but that may not be the whole story for the future. Once relationship was built, I started to invite him. Maybe you can come to school and see me. We haven't really seen each other in person. I don't know how tall you are. I don't know what do you really want or like to wear besides pajamas. So I started to invite him to come to school to see me and also to just encourage him, why don't you just pick one class to attend? And after that class, come to the office and see me. So he started to attend school once per week. After that, more like longer time going on, and then he was able to come to school even though on the day that he was not seeing me. So maybe like 2-3 days per week. And then after that, he was able to attend 12th grade. But the new challenge comes because he wants to go back to China to attend college. He started to have a thought, what if at that time when I was in elementary, I did not come to the US, what my life would be different? So he really wants to check it out and want to go back. But he finds it's really difficult to apply college in China because his language, his Chinese is already like not speak and listen that well than before. But he also feels that he still has the responsibility to take care of his parents and also being a role model for his younger siblings, that if I just live and escape from the US, then my family needs to deal with all these challenges by themselves, that he feels that he's so selfish. So at that time, in the last phase of the therapy, we really talk a lot about what is your responsibility, what is your identity, what will be the balance. And that would be the long-term thing, that the challenge will be long-term. It's not just for this moment, but we can see from this case that there will be like some potential challenges, not just for school-based, but also that can be ongoing until they were being an adult as well. So we talk about some potential challenges for this setting, but what we can do, this is a very special setting as school-based. We can also use it as a resources. Like for, let's say if you're a clinician, right? work as a team with the case manager, with social worker, with family fiance. I find it for myself is very important and very useful. Let's say I was at that time, I was able to just go to the classroom or like shoot the case manager an email and find a time to talk and really sit and talk with the case manager to look around, oh, what's actual academic requirements and challenges the client that I have is like facing. Is that really so difficult, or maybe we can make a plan step by step that we will be able to go through it and overcome this. And family fiance, maybe they already have relationship with each other, and if they can speak the same language as the student, I found it I can get a lot of information from them. Maybe for me, I only see this client when he was like 11th grade, but maybe the family fiance, he or she already know this client for like back then for many more years than me. And after all, we can only see this client during the therapy section, one-on-one 15 minutes. And this is a very special setting as well. For them, they can observe clients in a very different setting, and even though in a group. So offering group space and time for them to connect is also very useful. I find it sometimes, but it can be like really build a relationship first. Because like when stories shared, connection happened, and then the student will feel less isolated. He feels that, oh, actually my story is a little bit similar with this one and that one, then the connections happen. Crisis resources is very important because no matter if you work at elementary school, middle school, or high school, they are also very important because they are all minors. So with all these resources in hand, that we will know when, what, and who we need to report to. Like some suicide prevention, like 5150, or should we talk with the case manager or like the caretaker? Some sexual crisis, unconsented sexual behavior, and we also need to know like who and what and when we need to report. If there is like some domestic violence at home or other factors is affecting. Some basic skills that if not just clinician can apply, even though you are a parent or you are a teacher, you are yourself, that you find is useful, that you can also just apply it in daily life. You don't need to be a clinician. But for me, I like to use it with my client. It's also like I don't like using it just like step by step. I like for this client, he also lost appetite when I saw him. But sometimes when we see each other in person, I allow him to eat. And sometimes he asks me if he can eat in the section. And since this is one of the symptoms, I encourage him to eat. And then like most of the time that when we were in section that we talk about a lot of like childhood trauma, maybe at that time that he found out at that time something happened in elementary that was actually bully, but at that time he did not know that was bully until he get older in middle school or high school now. So we spend some time to really talk about something happened, a trauma, or racial trauma happened before. So I find it very important to like a closing ritual for them. Just at the end of the section, I said, oh, how's your food? Oh, let's look at the picture, to just bring him back to here and now with an organic conversation. Not really like very obvious or anything. It's just very organic, and bring him back to now here, that you are grown up, you are safe, you are not in past when you were still an elementary student. So just encourage the clients in some organic conversation that will help him to ground before letting them to leave the therapy room. Some of the skills also like stop. Like for these skills, I find it's useful for like maybe clients have like self-doubt or like negative, like blaming or something, but it can be also used in a school setting, like physical conflict. But for my client, he's such a sweet guy. He doesn't really have like physical conflict at school, but this skill can be also applied for like a different situation. For this case, like let's say like he has some self-doubt or blaming, that I was just like, hey, let's take a moment, let's just respond, but don't react, and see what we can do. Maybe we can take a walk, maybe we can just like, okay, I usually pick him from the classroom, and then we will go around the playground before going to the therapy room. From that walk and talk, it's very useful for me to get into a check-in, like what happened within this week that we did not see each other, and what is your status right now? Can we go deeper this section, or should we just address what happened in this week that is like more surface and safe? That really provide a good sense of what we can do for the following 15 minutes. Observe, and if like, okay, maybe we can do something deep, then we can do about like some self-doubt or like self-blaming conversation, that, wait a minute, how do you feel? And how are you feeling when you have this statement in your mind? And wait a minute, once like now I have this statement in my mind, let's observe how other people react. Did they react differently? Or this is my own projection on them, thinking that they may think me as a value, or I really just think myself as a value? With these questions, reflective questions, then we can engage the clients to have more deep relationship. Then we can start, okay, do you want to be a value? If not, what's your goals? With these goals, what kind of option, what options that we can apply for achieving these goals? Then we can start to make a change. But yeah, this is some skills that maybe we can apply, but there are tons of more other like skills. Just listen to our clients and students, that we will find what helps. No matter what, I feel like therapy is not how skillful we are, how much skills that we have in our toolbox. It's like how we spend the time with our clients, listening to them and really know what's happening for them. And we are really being there for them. That is the most important thing in therapy. Thank you.
Thank you, Cruz, for sharing your like expertise in working in school-based, and also like giving us some very concrete, like specific skills that you see much work, and like that kind of foundation of like listening and being present that really resonates with me. So we will now transition to our next speaker, our last speaker for today. I'd like to introduce Diana Chu, who is a licensed marriage and family therapist and registered drama therapist who provides counseling services for Asian American adults and families in California and Florida. She leads workshops at national conferences for clinicians and provides mental health consultation for AAAI nonprofits. She is an interpersonal dynamics facilitator at Stanford University Graduate School of Business, supporting students in developing emotional intelligence, communication skills, and self-awareness. She worked at various community mental health settings, including Community Youth Center, counseling enriched educational programs, school-based counseling, family engagement programs, and more. Apart from being a therapist, she is also a board member in San Francisco's Telegraph Hill Neighborhood Center and is a part of the Lotus Project's Professional Advisory Board, and also serves as an education chair on the North American Drama Therapy Association Board. So it's a pleasure to turn it over to Diana, and thank you.
Thank you so much for the introduction, Angela. Hello, everyone. I'm Diana, and here's going to be something that I'm going to talk about today. It's my clinical practice about how to work with AAAI clients, family, and children. This is a pretty big topic, and it's a pretty near, dear, and to me. And what I wanted to share is like how to begin, where to begin as a clinician. Like what can we do to support the clients as they walk into our door? So a little bit about myself. just to orient ourselves, I want to give you a glimpse of who I am as it informs, how I treat and support my clients and my community. And also on my past experience, allow me to use different formulations in my brain of how I formulate cases, how I relate to my clients, how I bring myself as a person into the therapy room. So just like you, our lived experience, inform us about our world, the world, and my world might be different from yours. And but these are some of the parts of myself, and this will inform this presentation as well. So a little bit of highlight, I'm an immigrant from Hong Kong, consulting for nonprofits, also speak Chinese, all these different parts of me. It's present in this presentation and present in my clinical room. So let's talk about this. So typically, when do AAAI typically, seek help? Like, where is their starting point? So where to begin? So let's go back to the moment when a client comes through the door. For the purpose of this presentation, I'll be focusing on clinical treatment. One of the things that comes in mind immediately is that they're like, I cannot handle this anymore. There are clients who are like, my symptoms, stressors have been increased. I'm not able to sleep. I'm not able to eat, or having all these depressive episodes that come out that they could not handle it anymore in a day-to-day. And that's why they seek help. It's like they passed the threshold, something that is like highly dysfunctional. And then the second piece that I see most of the time is, hey, my family member, my aunt, my friend needed help, or my family member told me to come, or my teacher told me to come. So there is an external motivation. There's someone that pushes them to come into the door. They might not have the buy-in yet of like treatment or clinical needs, or understanding what is therapy, or understanding what we're doing to support them, but someone told them that they should get help. And the third one is free service. Well, it's free, that's why I come. Which is great, because there's a lot of community outreach in nonprofits, in communities that would provide services. How can we understand their starting point? And once we understand their starting point, we can pair it, because the question transforms into why now? They could have come yesterday, they could have come, a few days later or months later, but why now? What do they need now? So this is just my view of, what I typically see. It might be different for different people, but like, for example, if they cannot handle it anymore, typically it's about symptom reduction. I'm not able to sleep. So we go into what's the baseline look like? What is that they were able to do before that they're not able to do now? Oh, I'm not able to sleep because I have nightmares now. I need to reduce the symptoms of flashbacks or nightmares. And so we focus on kind of like solution focus, on symptoms. And then there is the piece about the relationship. My mom, my sister, my friend, my daughter told me to come. Relationship as a motivator. Wow, they really means a lot to them. How can you use that relationship to be able to highlight that allow them to understand, oh, there's something that this relationship is telling them that they need help and need extra support. And so going into the relationship, understanding that dynamic could help with their need. And then the last example is the free service with the psychoeducation. How can the program, provide and improve the quality of life? Like giving them some nuggets of like improving what they need, improving their quality of life right now, so that they understand, like their what we can provide. So when we think about, where to begin, actually, we found the answer. It is these pieces here. we typically start with what they're looking for. We have only typically an hour to create, for them to create buy-in for this process. So will you be able to provide what they need? Some kind of relief in this 30-minute or an hour time, so that they have a reason to come back. We all know that like 1 hour is not enough to heal everything and to have a transformative experience. But how can we use that hour, that first touch, to create that relationship that motivates them to come back? If they're looking for symptom reduction, are you able to give them some skills? If they're thinking of like venting and talking about like how angry they are with their family member, are you able to create that release for them? So the first hour is really important because it creates that hook into more potential treatment or touch points. So next, I'm going to talk about what I've noticed when working with this population. There's one piece about the cultural needs. I remember one time I was doing some home visit to check on, an elderly, and who was a little bit older, and like she was actually cooking at that time when I arrived at their home. And what I did is that I sat down at their kitchen table and I peeled beans with them because she was peeling beans. And that act of, just sitting down and understanding and joining them in the process in the kitchen, allow them to kind of like, to become, get into the cultural piece immediately, because I'm joining the community, joining like what's normal for them, rather than, very clinically, like I'm gonna sitting across them, looking at them peeling beans rather than joining them. So this is just a snippet of like what I would do when I pick up, the needs of the client. So cultural needs, language, how can we pair clinicians that have different similar language or cultural background with the clients so that they could understand each other better? What is the approach of the clinician and how do they build rapport? And then the second piece is the level of trauma. Like, what is needed? Is it individual treatment or group therapy treatment? Some level of trauma is not appropriate to share in a group setting because the safety of the group is really important. However, when some of the intense symptoms is alleviated, a group treatment would be appropriate. So it depends on like, what is the level of trauma of that person, and like triaging to the right groups and support will be really important. And then also the last piece is financial investment. Is it free or is it private pay? Is it free for the client or do they pay out of pocket? What I notice is that throughout the years in nonprofit work and also in private practice, I do notice that like people who come knowing that the session is free, even that they're paid by a nonprofit, they actually might have more cancellation rate or no-show rate. So how can we, even though that they know that this is a service that is free for them, how can we motivate them to come and to get what they need? So I'm going to share a little bit about what worked in my practice. This might be a little bit interesting because I don't have a lot of time to go in on the cases, but I'm going to give you a snippet of that. There's two different focuses in my practice as well. One is drama therapy and also EMDR, eye movement desensitization reprocessing. So a little case of drama therapy is that like it's very playful, it's disarming. For example, I have a client who have a hard time thinking of resources that is in their life. And so what we did with this teen client is that we have a hot pot. We dramatized the play. And so rather than picking up food from the hot pot stove, we actually pick up resources from them. So we also talked about like, okay, oh, if this piece of meat is representing friendship, okay, so I'm gonna go and get some friendship from the hot pot. But how long does it take for us to marinate that friendship so that it's ready for us to absorb in our body? So, oh, I need to, so the team was able to come up with like, oh, I need to work on my friendship, in periodically, so that like my friends are there for me when I need their help. And it's pretty fun. It's pretty fun for me and pretty fun for the team as well. And then the other piece is like role playing, like I use role playing a lot. It allows us to take, the client to have different perspective taking, role playing. Oh, your parent, like, or like, what would it be like if your parent experienced what you just experienced at your age? What response would they have? Or giving voice to the silent part, the unspeakable, the guilt and the shame, so, like role-playing anxiety or role-playing depression. And so that's like something that I do. And then the other piece that I do, I'm also trained in EMDR, which process like traumatic events and memory, which I found very, it's a great tool for this population as well. Because what I notice is that the client do not need to tell all the details in EMDR process. So as you know, like sometimes in Asian culture, there's a lot of secrecy, shame, or guilt that is stored. And they might have a hard time trusting the therapist on holding the story as well. And so EMDR allows that to happen, allows healing and reprocessing to happen without knowing everything. The clinician doesn't need to know everything. So it also helps decrease symptoms, and it's very structured as well. So the client is able to know exactly what will happen in the therapy session. So this works really well for single traumatic events that I've experienced, and it kind of like lowered the symptoms immediately. So a case would be something like, someone got snatched, their bag, robbed by some thief that like have a car, and they came out of the car and grabbed their bags, right? And so the client have the symptoms of flashbacks and the symptom of like, hypervigilant. Whenever they see a car with tinted windows, they already like kind of like clammed up and like have anxiety. And so I focus on that image in EMDR and just lowering the symptoms. And so they're able to function, closer to baseline after that treatment. So I found that like these two practices work really well when treating these kind of clients. And then I'm going to talk a little bit about considerations, things that you might not have highlighted in school. It's the importance of rapport. Sometimes when we build rapport, we talked a lot about like food, body aches, sleep. I think like, in Asian culture, rather than talking about feelings, people are more likely to talk about, oh, I have like this back pain, or like, like I just ate, whatever, like, so those are like my go-tos when checking in with my clients. I also have, this highlight of like, like noticing that like as a therapist, a lot of people see you as a teacher-student dynamic, teacher, or doctor, can you tell me what I should do? What does the same, can you treat me right now? So like focusing on that dynamic and noticing it, like, what kind of dynamic the client is giving me. And then the third one is building safety. Can you build safety with the client? And then the second piece is the guilt and shame. Understanding what is the in-group and the out-group, some of the secrets that like the family legacy have. I have clients that like the secrets is that like, like they have something happen in their relatives that they would never tell people about it. And as a clinician, you might find out about it like 3 or 4 or 6 months later. Sorry, a little bit cough in my throat. And one other consideration is that you always remember that you are an outsider in the beginning. Like, how can you gain trust with the client? And then the third thing is cultural and spirituality. What are some of the rituals that like the client have? Are they going to talk about spirits, ghosts, qi, feng shui? If you and also at the same time understanding like the dynamic of collectivist and the individualistic parts of self. Because in some ways, if we're changing one thing, it changes everything. So if they change how they relate to a family member, it creates a ripple effect in the family dynamic. So lastly, I'm going to talk about how to support your clinicians and staff, because I found that really important, and how to support the whole organization is really important. Because not only the treatment of the client, if you're able to support your clinicians who are treating the population, it creates a better, cohesive unit and a better support system for the clients as well. So invest in great consultation, supervision, considering hiring outside providers who have cultural understanding of that particular population that you're working with or the group is working with. And then the second piece is creating an environment that welcomes questions, from, documenting notes to understand like countertransference or ask weird spiritual practices, like having that open, question, like experience would allow clinicians to ask more questions because there's a lot of weird or, uncertain like things that cultural practices that people might not have exposed to. And there's so much different dynamics in different Asian cultures. And then lastly, share the business side. How does the funding works? If the clinician do not understand like how fundings or the grants work, it will allow, it doesn't allow them to understand, how money comes from and like how to support the program. So what can we do to provide that boundary? On the line of like providing support and also the business side. So I'm going to leave you with this. So it's a Chinese saying that like one stone can cause 1,000 ripples. It might seem small, but what you're doing or what you will be doing will create an impact. And I hope that this presentation will create a little impact on you all and inspire you to creatively provide treatment and support to your clients as well. Thank you so much.
Thank you so much, Diana. I mean, you really kind of brought it full circle about, even sharing like what EMDR and a little bit about drama therapy, bringing your own personal professional experience, and then bringing it back to the provider about what can we do to support each other. I mean, I'd like to now switch, to our full panel, and go to our next segment about with our panel discussion. I have a couple of questions, but I also want to give the audience a reminder that they can also ask questions and to upvote, and we'll have a couple of questions that we'll be able to bring forward. So yeah, so good to bring the panel back again. So I get to have the pleasure of being able to pose 2 questions. So my first would be, among our Asian American and Asian immigrant children and families, can you share if and how the presentation of clinical symptoms and mental health concerns may have changed between now and before COVID, which we know was a time when a lot of racial stress may have risen dramatically for many? And please feel free to unmic and share.
Anyone want to go first? Okay. Well, from what I noticed, just like bear in mind that like, what I see is really just my clients. What I notice is like a higher level of anxiety and also like depressive symptoms and stress. I also notice about a higher level of agoraphobia, which is like a fear of going out. Like clients reported that like, I don't know if I want to go out or not, or like the decrease of like exercising and going out socializing. So one thing that I, also notice reporting is like, I think it really depends on the local incidences, how media shapes our mind. But at the same time, it's about class as well. If a person who have, the privilege of like having a car, it will be very different from like, if they're transporting in a bus all the time. And also like if they're in suburban area or like the city area, I myself is located in San Francisco, like how does that impact my clients as well? Location wise is really important. So I think like, like this is what I noticed. I wonder about like how other panelists also notice.
Yeah, I agree with like all Diana just shared, but I want to add on something like in school-based, some of my students that they will feel like, oh, should I wear a mask or not? Or if I wear a mask, it feels like I'm not cool, but also like it's like a mandate. Like at the very beginning of the pandemic, and also like just when they back to school, just at that time, there was like a lot of anxiety of like, what should I do? Should I do this or should I do that? Should I wear a mask or should I not? That really brings a lot of anxiety about, oh, is that my own decision or it will be affecting others? And also like that kind of thing is not just school-based. I noticed like that's also like on the street as well for just like whatever people.
Yeah. I also want to add that I think it's important for us to recognize that Asian American, especially a female, their suicide rate has been growing since 2017. So especially age 15 to 24 years old. But then after pandemic or during the pandemic, the suicide rate has been even going up, right? As my study shows that. So I think this has so much implication that, we cannot just leave it alone like this, right? And we know that, these young people are suffering so much. And as Diana and Cruz talk about, the anxiety and depression rates were high to begin with, but it's even higher. And there's a sense of fear. And not only a sense of fear, there's such a helplessness. And these women or men are questioning about their own racial identity. What does it really mean by being Asian? And they start thinking about or start doubting about what they have learned so far and what they have believed so far. I thought if I study really hard, I can go to really great school and I can go to, I can get a great job and my life would be pretty much successful. That was a very realistic, simplistic kind of linear way of thinking. But then realized that, wow, I thought if I work hard, I'll get this linear thinking. No. It is not true. They're beginning to learn about how complex it is, this world is, and this US is, how race has been impacting the way that we see our values, the way the possibility of being promotion or possibility of getting a job, good job, great job, or getting married, all these kind of things. So now these young people are beginning to questioning about the meaning of life. And I think this is a really serious problem because it increases the distrustworthiness, sense of distrust toward this country and in their meaning of their life. And there's having the existential questions about what the life meaning is.
No, thank you for everyone for sharing your thoughts around that. And, given that there are, symptoms or the presentation of concerns have changed and changed a little bit during this time period, what are some things that you all might think that we how would it, the implications for our practice as clinical providers when we engage, or how to even notice those things, or when we work in a school community and we're talking with different educators and things. What are maybe examples or factors that we should consider when working with those impacted by racial stress and trauma?
I found it like for therapy, the format, like during the pandemic, we really being more like organic or flexible, that we usually see clients like in person before the pandemic. But now, like if they really like suffer from agoraphobia, that they don't want to go out, then we can also provide like online section. And for that, when they were feeling like, oh, I am now in a safe space, that maybe at my home, or if like my some other family members, they are outside of the bedroom, that I feel like at least I am in a safe better, that really I find this can be a way of better.
I just want to share one thing that, during COVID and since COVID, I also experienced racial discrimination, and it's very, how can I say, it's not very obvious. No one came to my face and shouted at me that you Asian, go back to your country. No one has done that, thank God. But I feel the uncomfortable feelings, that I am not welcomed, okay, and they don't want to be around me, that sort of feeling, the sense of rejection. And I have felt that even though I'm very successful from my academic perspective. But when I experience these kind of things, wow, this is racial discrimination, because there's nothing that describes these kind of uncomfortable feelings, okay? And it really totally makes me very, very sad, okay? So there's a sadness, there's an emotional component or emotional reactions that I experience, but there's another reactions, okay? And I came to the conclusion, I'm gonna skip the whole thing about my struggles, okay? I came to a conclusion, just one thing. I was born to fight. That's the quote. I realized that as long as I live in America, I'm gonna have to be the fighter. Meaning that I have to fight with my own emotion, okay? That these kind of feelings that, oh my God, people are treating me like this way. This is ridiculous. Okay, so I'm fighting against myself, but I'm also need to fight against this society. We cannot accept this treatment. We cannot accept dehumanization. Are we going to inherit this dehumanization to our own children, to our own grandchildren? This is what has happened because our ancestors, those people who have lived in America 30, 40, 50, 60, 70, 120, 100, 200 years ago, they didn't fight enough for us, okay? And I am not going to accept that. This is why we have to get together and we have to work together collectively to fight against with the government, meaning that this structure, this racist society, this racist structure and policy that disadvantages, these Asian Americans or other ethnic minority, we should not tolerate it. We have to work together as a unity, unified group, and we have to constantly push back. That's the way that we will be able to survive and thrive. We want to be highlighted. We want to maximize our potential, don't we?
No, thank you for that. There's a question from the audience that I think is kind of related. Is how has your experience as an Asian American impacted the therapeutic relationship when working with other AAPI clients? And yeah, this question is open for anyone who feels like they want to share.
Yeah, I'll be happy to share about that piece. My experience, I come from as mentioned, like from my own background, I think like it's really important to bring ourselves into the therapy room when working with clients. And at the same time, just to highlight that, like, I myself is also experiencing the pandemic, as a clinician. I myself is also, like being impacted by the media. I have my own feelings about those, accidents or incidents that happen in my own culture. Right, like, and I have my own family that I'm thinking of during the pandemic. And I think like, one piece that like I really, was helpful for me is finding clinicians that it's similar to my background, creating consultation groups, consult with them, talk to them when all these kind of come up. I think this type of forum is like the perfect way to connect and like, exchange contacts and create that network and support as a clinician, but also as a provider, because like the better you are in understanding your own process, the better you are in supporting your clients as well. And so that's like what I've been doing, go to consultations, supporting the, different groups and communities so that I could put my outward energy out in an effective way. And so that I get fed, my soul gets fed, and then I could like support my clients in a better way. And I think also really understanding the psychodynamically, understanding transference and countertransference as well is really important. When working with clients, is like, what is my stuff and what is their stuff? And so that like the treatment could be more effective.
And I find it like as an Asian American, sometimes when I work with children, and that also provides me like resources to work with family as well. And when I need to do like collateral section like that, me myself can be a bridge, no matter for the language or for the culture itself. Like it can be like a bridge for generation. For family, that is also very important and very interesting to notice as well, like just because I'm also an Asian therapist. Yeah.
Thank you. Another question that has come up is around, it's switching a little bit, but the efficacy of drama therapy. So there's a question specifically about how does this, if someone could speak to the efficacy of drama therapy specifically with this demographic, what would that look like?
Yeah, I could talk a little bit about drama therapy. It's interesting how Cruz and I are both drama therapists. Maybe it's because we're like, we talk a lot.
With a lot of gesture.
Drama therapy has very specific, training, and I think like you can Google it, and there's an organization called North American Drama Therapy Association, and that would create some, give you some insight of like what drama therapy looks like. So specifically with the demographic, drama therapy works for anyone. From young to, like a different age range to different disabilities or abilities groups. I found it very useful because in my clinical training, like I use a lot of metaphors, sometimes it's about poetry, sometimes it's about drawing, sometimes it's about like role playing. I found it really fast for my clients to, get into the material that they want to get in. And also like specifically with role playing or interviewing, the client, it creates this dynamic where we are working together on the issue, and the issue is like in the therapy room. So I found it very helpful myself. Drama therapy also works with groups as well, and individual groups, couples.
Mm-hmm. And I think like if we really like want to know about like drama therapy, but it sounds like very broad. Like drama therapy, I understand it's like an umbrella. But for the first tasting, if you just want to like taste what is that but also we have a lot of different approach under this umbrella that call like psychodrama, developmental transformation, we call DVT, or some like just like performance approach like playback theater. That can be also some like tasting. Oh, I just want to know about some techniques or something to just get to know about what is drama therapy. That can be something that we can just like go to the performance or like, oh, okay, check it out. What's like drama therapy or developmental transformation. They are all under the umbrella of drama therapy. I hope that helps.
Thank you for that. This might be our last question, and I think an important one. All the questions are important, and this one is the last one being around self-care. So for us as a providers, and also how do we discuss self-care with our community, with whether it's clients or maybe there's something in the research that about how do we discuss things like self-care when it's sometimes not really thought of to be prioritized among our Asian American and collective cultures?
Well, it's I think like self-care is like, we talked about it as beaten to death. Like, I feel like we talk a lot about it, but it's really about like the practice, each of us. I have clients who do not realize that self-care is the same, like that thinking about the relationship of self, with yourself, they might like stop when I ask like, oh, so what's your relationship with yourself? Like it kind of like stunts them, because they're always thinking about the collective, thinking about like giving, thinking about like, how can I support my household, support my family. And so I think like, in terms of self-care, really finding like what works for you as a provider. I myself, I love Legos. So my self-care is, I have my own Lego building, things that I do after, my work. But also it's creating boundaries and structure. One supervisor that I had before really, thank my supervisor for giving me this tip is like, how can you, separate your work and personal life? And what she suggested was like washing my hands, in between sessions or after sessions, especially if I'm working from home, that differentiation is really important. And so like creating like these boundaries, like, the sensation of washing the hands, cleansing, that allowed me to like, understand that like, my work is done for the day. And so that this is my time now. And I think that like that, always talking about like what works for you might be different from other people. And you need to find your own way.
Yeah, and I like Shabby, like self-care is like, you are not just taking care of yourself, but when you're taking care of yourself, actually you are preparing yourself to be able to take care of others that you care for as well. So it's also very important when we think about, oh, am I selfish? Just thinking about myself, but actually, if you are not okay, how can you take care of others? Yeah.
That's good. And self-care, I think it's really critical to establish the routine and try to stick with the routine, because a lot of times when people are not feeling well, they don't want to do anything. They just want to crawl into their bed or sleep or avoid going outside, avoid exercising, avoid, eating. It's very easy to be addicted to the Netflix, right? There's some good Netflix series I can tell you too, but but I think it's really important for us to exercise 30 minutes, 40 minutes, 50 minutes. Just walking is totally fine. So establishing a very routine, that you really stick with, that's going to be one of the most important thing. And then number two is meditation or prayer. I think just when you're walking, just pray or meditate to whatever, just think about the positive things, or discovering the positive things when you're walking. It's called AWE therapy. I think that is also really, really helpful for you to always experience something positive, experiencing refreshing every day, discover something new for yourself or for others or in the world. I think those things are really therapeutic.
Yeah, no, thank you. I mean, those are really resonate, and it really makes me think about all the ways that we can reset ourselves and kind of share out and when it comes down to it, it's also like, I'm also thinking these forums that we have when we actually are talking and sharing. And even if, we have different ways of approaching things, it's that conversation and kind of the feeling of community. I think really brings us together. I have learned so much in this last, almost 90 minutes. It's been really wonderful to hear about and heartening. I mean, it's very like a deep topic, but it's been really good to really talk about like the from research and really current research findings, how it implies our practice to the work that Diana and Cruz that you're doing, and Chris as being at the university. So thank you so much. And I know, and I'll kind of pass it on to Ellen.
Okay.
Thank you.
Yeah. Thank you everyone for attending this webinar and also for the speakers for sharing so much about your expertise, and for Angela for moderating such a just colorful discussion between everyone. I think this is something pretty unique about like these webinars. It's just to hear the conversations that come up when you put everyone in the same room. And I also just want to thank for the audience, like those who were able to join via phone if you were having technical issues joining on Zoom. That's something that we'll also be working on after this. And this webinar is the second of 3 webinars that's addressing racial trauma among Asian American and Asian immigrant communities. So our 3rd webinar of this series will happen in August. Once the date is finalized, we'll also update everyone, but this 3rd webinar will be focused on community programs and action. So we learned about clinical implications for this webinar. The next webinar will be more focused on what community and prevention programs and other community solutions have been developed to address racial trauma and support the mental health and well-being of Asian American and Asian immigrant children and families. And then other upcoming events from the Lotus Project as well. On June 21st, 2023, we'll have a webinar focused on Afghan refugee child trauma treatment. And this event is also commemorating World Refugee Day, which is happening the day before on June 20th. So registration will be open for that soon as well. It'll go out to you all. And that's June 21st from 10:30 a.m. to 12 p.m. PST. Lastly, we have a workshop on May 18th, 2023. So this is an in-person workshop that'll be happening in San Francisco. And kind of summarizing a lot of what we're addressing in these webinars, how to better support the Asian American, Asian immigrant community in healing from racial trauma. And so that will be on a Thursday, May 18, from 9 a.m. to 4:30 p.m. Pacific time. And registration will start at 8:30. Lunch will be provided. Registration is open now. So that will also be sent out in the follow-up email that will go out to you all. And so in this follow-up email, it'll include the recordings from today, and as well as speaker slides and contact information. So we weren't able to get to everyone's questions today, but if you do have any additional questions, I'm sure the speakers would love to answer them. So that'll be sent out in the email along with the evaluation form, which Min has been sending in the chat. So if you haven't had the chance yet, please take the time to fill that out to receive CE credits and also just to help us improve our future webinars. And that concludes our second webinar. So thank you everyone for taking the time to come out and join us.